questions and discussion towards the end here. It's a little bit high level overview of implementation strategies and our work there. Just in terms of what I hope to accomplish today, hope to provide a broad overview of implementation strategies and give you some tools that can help you to name and describe implementation strategies, and then start to present some systematic approaches for developing and tailoring implementation strategies. Dr. Spring has already seeded the ground nicely with MOST and other approaches like that can be used to optimize implementation strategies, and glad you'll have exposure throughout the Institute to additional resources on that front. And then I'm going to share a bit about the shift towards thinking about mechanisms of implementation strategies and how and why they might work and when they might have unintended consequences. So just to start off and to sort of level set here, we've defined implementation strategies as methods or techniques used to enhance the adoption, implementation, sustainment, and scale up of a program or practice. And these next two terms are not necessarily used consistently in the literature, but we often talk about, discrete strategies or single actions or processes that can be used to implement new interventions. So things like clinical reminders in an EHR, audit and feedback, where we may measure a provider's performance and feed it back to them in comparison to their peers or an established benchmark, or in my area of mental health, something like clinical supervision, where we may provide direct support to clinicians delivering intervention. Oftentimes, given the complexity of the problems that we face in implementation and the complexity of things that we're trying to implement, we need multifaceted strategies or implementation interventions that combine multiple discrete strategies, hopefully in a way that's synergistic and well matched to the types of challenges that we're facing. As Dr. Spring has noted in her presentation, sometimes we use sort of kitchen sink approaches rather than a more principled approach to designing these multifaceted strategies. So hopefully in this presentation, I'll give you some tools to develop these thoughtfully and streamline our approaches to implementation so that they're not necessarily too clunky and expensive. Just to start off with some basic examples, and I won't go through this entire table, but just to give you the idea of some examples of implementation strategies, but also how we would like to sort of think about the alignment between implementation determinants or barriers and facilitators, implementation strategies, and the types of outcomes that we're trying to achieve. So if we have something like a provider skill deficit, it may be that training and in particular teaching and practice with corrective feedback is an appropriate discrete implementation strategy. That might operate through the mechanism of skill acquisition, refinement, and mastery, and be reasonably linked to something like fidelity to an evidence-based practice. On an entirely different level in healthcare and mental health care more broadly, turnover is a huge challenge, obviously. So an approach like train the trainer that may operate through the mechanism of ensuring that real-time training and consultation is available at a local level may influence an implementation outcome like sustainment or sustainability. And so what we'd like to see here is very tight connections between the types of challenges we're facing and the strategies that we use. And again, these are examples of discrete strategies. I should have noted on the prior slide, many of these discrete strategies are quite complex in their own right, could be operationalized a number of different ways. And those different operationalizations of the strategies matter. And so we would look to theory and evidence to hopefully operationalize them in ways that will enhance their effectiveness. This may be a bit much for the third slide here, but just as an example of a multifaceted, multi-level strategy, this is work from a colleague, Sam Schilling, at the University of North Carolina, who is a pediatrician and a child maltreatment prevention specialist, who has an evidence-based intervention called PriCare, which is a parent training program delivered in primary care settings. And the green oval here is not maybe a traditional implementation outcome as you might think of it, but really the linchpin of this evidence-based practice that Sam and her colleagues found was actually getting physicians to refer to this PriCare intervention. And so what you see in the rectangular boxes here are in fact implementation strategies. And maybe this is not a perfect rendering of how they operate, but in this case, Sam and her colleagues hypothesized that public recognition for physicians and parent narratives of sort of their experience of the intervention would work in an accumulative fashion to improve clinician motivation to deliver this or to refer to this intervention. She also hypothesized that that audit and feedback, actually measuring their referral rates and feeding that back to them in comparison to their peers, would amplify the effect of those two implementation strategies on clinician motivation. And that preparing parents to be active participants by MyChart pushes that would describe the intervention and hopefully motivate parents to engage in that would improve parent motivation. She also thought that clinician motivation and parent motivation would converge to improve the parent-clinician interaction, that would facilitate discussions about this intervention and hopefully ultimately engagement. And then finally, she used a clinician reminder in the EHR to remind physicians to refer to PRI-Care, hopefully facilitating the effect of these interventions on her ultimate outcome of interest, which is PRI-Care referrals. And this was really tested using sort of a simple quality improvement design. So this was not a large randomized controlled trial or anything, but showed that she could improve referrals from 13 to 55%. And I think in this paper, Sam does a really nice job of talking about sort of the theories and theory and evidence behind the selection of each of these implementation strategies. So a nice example of justifying the choice of implementation strategies, both in a multi-level context and as individual strategies. So the first sort of chunk of content that I wanted to deliver is just to suggest that we have tools to help us to name and describe implementation strategies. These should help improve scientific communication and reporting in the field, but they certainly should not constrain our creativity or options for implementation. And so I'll present some established compilations of implementation strategies and behavior change techniques, but just to say this is an evolving field, and those compilations have evolved already and will continue to evolve as the field advances. But fundamentally, these address a problem in the field, which is a need for improved specification, tracking, and reporting of implementation strategies. And so oftentimes what you see if you look at the implementation literature is inconsistent terminology and poor tracking, specification, and reporting of implementation strategies across the literature. So we often don't really know how people got from point A to point B. Sometimes the same strategy term is used to describe completely different approaches, or different strategy terms are used to describe essentially what is the same thing. So that introduces this problem of sort of pseudo innovation in the field. And there's really inconsistent terminology and reporting across studies. And this obviously limits replication in science and practice. And ultimately, as I'll get into towards the end of the presentation, precludes answers to how and why implementation strategies work, or this idea of understanding implementation mechanisms. So one of our first efforts to try to address this, what's been referred to as the Tower of Babel problem with implementation strategies, was to establish a compilation of discrete implementation strategies. This began with a literature review in 2012 of the health and mental health literatures that originally identified 68 discrete implementation strategies and defined them. We actually originally were looking to assess the evidence base for different implementation strategies, and realize that before we do that, we need to come up with a common terminology for these strategies. So that was a first effort to do that. And then in 2015, we were approached by colleagues from the Department of Veterans Affairs, so Joanne Kirchner and Tom Waltz and colleagues, and we proposed this expert recommendations for implementing change project, which involved a modified Delphi process and a concept mapping study, concept mapping being a structured sorting and rating process that yields conceptually distinct categories of in this case implementation strategies, but any topic of interest. And what we ended up with through this project was a compilation of 73 discrete implementation strategies that was ultimately organized into these 9 different categories. I'm not going to go into the sort of individual strategies here or the categories, but you can take a look at the references below if you want to do a deeper dive on these strategies. And I will note that the additional file associated with that Powell et al. 2015 paper has some of the more complete definitions with some examples and ancillary material for each of those strategies. We thought that this was a good start in terms of a compilation that was vetted by experts in implementation science and practice, but there were certainly a number of limitations here that have been addressed throughout the years and continue to be addressed as this work advances. But we hoped in developing this compilation that we would have a set of building blocks for multifaceted, multi-level strategies that would be useful in research. So if people are developing or conducting trials of implementation strategies, for instance, or conducting other experimental or observational research on implementation and want to identify implementation strategies using consistent language, hopefully it is a useful tool on that front. Hopefully it at least in some way addresses the issue with the Tower of Babel problem in terms of promoting a common language and improving reporting in the field. But again, plenty of room for critique, dialogue, and ongoing refinement. We've been pleased to see this picked up in the US and internationally by a number of federal institutes, but also really more pleased to see it refined over the years and advanced as colleagues pick this up and use it in various ways. What I wanted to point out on this slide is this is work from Sherry Rogal and Very Yakovchenko and colleagues at the Pittsburgh VA and the University of Pittsburgh. They've actually used this ERIC compilation by turning it into a survey that they've used to retrospectively and prospectively identify implementation strategies being used in implementation efforts. The red box here points to some of their survey work, which continues to be refined, informed by frontline providers and others in the field. And so they've done a lot of great work in this area. They've also, just point out quickly, utilized configurational comparative methods, these 2 papers on the bottom right, which are really meant to address the question of which strategies, in this case, are both necessary and sufficient to improve their outcomes of interest. And so just from a method standpoint, if you're interested in those methods, would point you to those papers as nice examples of those approaches. We've also seen, that this compilation was meant to be sort of broadly applicable and generalizable to other areas, at least across, mental health, healthcare, social services. But we've seen specific applications, for instance, adaptations of this compilation for school mental health or school-based implementation research and practice. Perhaps particularly relevant to this group, we've seen implementation strategies for digital mental health interventions in healthcare settings. This is led by Andrea Graham and colleagues at Northwestern. And also used as a basis for a scoping review and behavioral health by Alex Dopp and colleagues to identify financing strategies in that context. On another level, we've also been, I'm not sure if this group has talked about this notion of de-implementation yet, but the first paper here on the left focuses on the specific phases that these implementation strategies would be useful in. And so beginning with sort of exploration and preparation processes before we actually implement an intervention, and then moving on to implementation and sustainment. This is a paper led by Nicole Nathan and colleagues at the University of Newcastle in Australia. And I think usefully categorizes the ERIC implementation strategies according to these various phases. Again, may not be a perfect mapping, but the idea is that some of these strategies may be more or less useful at various phases. And if we think about sustaining interventions, there may be some additional strategies that are necessary, and again, room for creativity and further development on that end. We've also used this as a basis for to categorize interventions for de-implementation of low-value care. So this notion of de-implementation or ex-novation or other terms that speak to the need to get people to stop doing things that are no longer effective or may even be harmful. And the ERIC compilation did a decent job of serving as a categorization scheme for those de-implementation interventions. And so I think you can think about using the compilation in that way as well. The original work that informed the ERIC compilation was really North America centric. It was primarily folks from the U.S. With a lot of emphasis on the Department of Veterans Affairs. And so increasingly we've been asking, how do these strategies apply internationally and to low and middle income countries? My colleague Kate Lavero at Columbia University has conducted a systematic review of the use of the ERIC compilation in low and middle income countries and found increasing use and relevance in those settings, and also probably some areas where it may be less well fit. And then we're also seeing an increasing number of translations of the ERIC compilation into other languages, and hopefully increasing its use and sort of pressure testing its utility internationally. So hopefully we'll see more of that work forthcoming. And then finally, on the sort of strategy categorization front, I wanted to point out some other taxonomies that you might see. Many of you may be familiar with the behavior change technique taxonomy developed by Susan Mickey and colleagues in the UK. This work is actually advanced and as linked below into the behavior change technique ontology. And so they've done a tremendous amount of work on that front, and I think a lot of those papers are linked at that bottom welcomeopenresearch.org link. These are behavior change techniques are described at a bit more of a granular level than most of our implementation strategies are described in the ERIC compilation and other broader compilations like that. The paper in the middle here by Sheena McHugh at University College Cork in Ireland actually talks about how these compilations are complementary. So we can think about a strategy like audit and feedback, for instance, as is illustrated on the right, which we might define as collecting and summarizing performance over a specified period of time and giving it to clinicians to monitor, evaluate, and modify provider behavior. That can actually be made up of a number of behavior change techniques. These are just two listed here, but feedback on behavior and feedback on outcomes of behavior. Depending on the way we operationalize audit and feedback, a number of other behavior change techniques might actually come to play. And so this is another way of specifying your interventions in detail. Even if you're using the language in something like the ERIC compilation, you may have opportunity to specify it further using behavior change techniques or behavior change methods as described by Koch and colleagues in the reference below. That's a method that's very tightly connected to the intervention mapping or implementation mapping literature, which I'll reference here in a few slides. So I mentioned inconsistent reporting in the field, and one of the tasks of implementation researchers or others who are reporting implementation strategy use and research manuscripts or other practice focused literature is to really carefully specify the strategies. And Enola Proctor, Curtis McMillan, and I years ago suggested that people carefully name implementation strategies using language that's consistent with the existing literature. And that is, one way of doing that is through the existing compilations that I've mentioned on previous slides. Again, those shouldn't necessarily constrain our thinking, but to the extent that your strategies fit with those, using that language can be quite helpful. But then defining the implementation strategy and any discrete components operationally, so specifying who are the actors involved in this implementation strategy? What are the specific actions that that they're taking? And the third is sort of, what is the action target? So this, you could think about this as like the specific barriers and facilitators you're addressing. I think if we rewrote this paper today, we'd have an increasing focus on sort of the mechanisms of the implementation strategy at this point. Is there anything about the timing or dose of an implementation strategy that needs to be reported? What are the implementation outcomes, or might even say, what are the proximal, intermediate, and distal outcomes that your strategy is addressing? And then what is the empirical, theoretical, or pragmatic justification for the selection of these implementation strategies? I think that's often missing in our work to really clearly justify why we're doing what we're doing. And again, just to emphasize, like, if we had a multi-level or a multifaceted implementation strategy, it'd really be ideal if each of the discrete components are reported using this type of detail specified in the figure on your left. I think as Dr. Spring mentioned well, the need for iterative approaches and that change is really inevitable, probably both to our interventions and our implementation strategies. So the figure on the right is just meant to suggest that even as we describe planned strategies in detail, such as through the figure on the left, we want to track implementation strategy use over time. And as we sort of monitor barriers and solutions across the course of an implementation effort, we may have modifications to the planned strategies. And so we may, for instance, eliminate some strategies that aren't working. We may change some strategies in the details of those strategies over time. We may add strategies as necessary. Of course, this is presuming that your study design allows that, or if it's a more practice-based effort, that's sort of kosher given the constraints of your research design and approach. But we want people to identify and describe those added strategies or any changes to implementation strategies using a similar level of detail as specified on the left. And so the references below here are a number of papers that talk about different methods for tracking implementation strategies. Certainly one of the challenges is, how do we do this pragmatically? This is sort of a lot of work, and there are questions about, how much the juice is worth the squeeze from an analytic standpoint. But this is one way we can think about tracking sort of fidelity to our implementation strategies at a foundational level. And again, noting, how we got from point A to point B, and hopefully being better positioned to understand why our strategies succeeded or failed at the conclusion of a study. So transitioning a bit to systematic approaches for developing and tailoring implementation strategies, and we have a number of approaches on this front. In fact, I'm just presenting a few of them here today, but there are many more. One of the things that, at least is my opinion, is that the components of these approaches are often similar and overlapping. And so you might see different names for different approaches, and I'm not suggesting that they don't matter, that they don't have their distinct advantages or disadvantages, but fundamentally a lot of these involve similar steps, and so I'll sort of go over that a bit. And I do think there are opportunities for all of you and for the field to think about further development and comparison of these different approaches. And so there might be even opportunities for head-to-head testing of different approaches for developing implementation strategies. And I think that the field continues to evolve on that front. I'm just going to quickly fly through these. There's a number of potential pitfalls when designing implementation strategies. If we had more time, I would sort of ask you how you see this done in your work or in your experience in the field. But I think many of us have been exposed to sort of the train and pray approach. So, we're trying to implement things using the train and pray or hope approach, like that we send people to training, hope that their behavior changes. But oftentimes we know that sort of educational approaches or training approaches are necessary, but not sufficient to promote the implementation of evidence-based practices. The other thing that we see frequently is sort of, we've always done it this way. So whether it be an organization or a system level or even an implementation purveyor, they may have sort of go-to methods. So for instance, we always just use plan, do, study, act cycles, or we always use learning collaboratives or training, or whatever the strategy may be. They may have a fixed approach to implementation that doesn't necessarily respond to the specific interventions or context in which implementation is occurring. Again, Dr. Spring mentioned the kitchen sink approach, and at least in this is I guess over 10 years old now, but there was literature that suggested simply adding components to an implementation strategy didn't necessarily make it more effective. So the notion here is that we may have a multifaceted strategy, but there might be reasons why that's not as effective as single component or simpler strategies. One may be that it might be multifaceted, but it might address sort of the same level. So you can imagine multiple strategies addressing the provider level while ignoring, through training and supervision and things like that, while ignoring organizational or systemic problems or even patient level barriers to implementation that may need to be addressed. We also see oftentimes a mismatch between the challenges that we face and the strategies we use. So there's also the notion that a multifaceted strategy may be sort of mismatched with the context and the challenges that we're facing. This is an area of a lot of ongoing work and frankly conceptual lack of conceptual clarity, but one might argue that we too often use a one-size-fits-all approach to implementation, that our implementation efforts and strategies need to be tailored to the specific interventions and contexts that we're working in. And so there's a lot of ongoing empirical work to test different approaches to tailoring and to even think about what does it mean to effectively tailor an implementation strategy to a given context. And then finally, this is actually from one of the original editors of our journal, Implementation Science, our field's sort of flagship journal, who said we often use the Aslogiatic principle, or it seemed like a good idea at the time. Again, maybe well-meaning, but less principled approaches to implementing new interventions. And I often have this quote from Michel Vensing and Richard Grohl, who suggests that there's often little association between the type of problem and the approach taken, the approach to change taken, and more particularly, they know this organizational and system-related problems tend to be ignored even when detected, favoring individual educational and psychological approaches. And so, again, a bit of a mismatch between what we identify as problems and the strategies we use to address them. So we've identified a number of priorities for enhancing the impact of implementation strategies. And this is, again, more than several years old now, but I think many of these continue to be priorities for the field in terms of enhancing methods for designing and tailoring strategies, specifying and testing mechanisms of change, improving our tracking and reporting of strategies. And I'm not going to address the last two priorities here too much, but this notion of really needing to conduct more head-to-head and comparative effectiveness trials of strategies, and increasing our economic evaluation of implementation strategies moving forward. So I mentioned a number of systematic approaches for developing implementation strategies, and I'm going to present real quickly 3 or 4 of those on subsequent slides. But I meant to again say that a lot of these have sort of common approaches, and so you can think about this as a general approach to developing theory-informed implementation strategies. Some of these approaches on subsequent slides may use different methods for this and may have particular strengths and weaknesses that we could talk about. But fundamentally, I think these are the basic steps that we're taking to develop strategies. For many of you who are intervention developers or who work in this space, these will be familiar as you think about developing interventions more generally. So the first step is really identifying who needs to do what differently in order for implementation or sustainment or scale up or whatever your ultimate outcomes of interest are to be improved. And so partly this step, one of the things to emphasize is that I think this has a lot of implications for equity. Part of this is getting the right people at the table. And so thinking really broadly about who influences implementation and who will be influenced by implementation, and making sure that those folks are informing our implementation strategies, and really thinking in a behavioral way about what sort of multi-level changes need to occur in behavior for implementation to be improved. The second step is to use informal and formal theories and frameworks to identify barriers and enablers that need to be resolved, and really articulate a pathway of change for the targeted behavior change to occur. And here is where I would mention a variety of research methods can be used, and theoretical and conceptual approaches. For those of you who are already quite familiar with implementation science, you'll know that we have like a gazillion theories and frameworks in our field. Many of those focus specifically on determinants or barriers and facilitators that may be important at various phases of implementation. And many of those frameworks would be very useful at this step, and sort of making sure we sort of are thinking about the universe of potential barriers and facilitators that could be important and addressed at this phase. And then a variety of research methods ranging from reviews of the literature. At this point, the literature is replete with studies of barriers and facilitators for different interventions or populations. And so starting there is often a good, just like any research problem, is a good place to start. Even conducting a scoping review or systematic review of barriers in a given area. Certainly more formal qualitative, quantitative, or mixed methods studies could be used to identify barriers and facilitators, and we could talk about different methods for that. And even informal consultation with your implementing partners could be helpful. After we've really hopefully developed a rich understanding of the problem that we're facing, and really how those barriers and facilitators relate to one another to maintain the implementation problem, hopefully we're moving on to selecting implementation strategies. You can think about that as both behavior change techniques and modes of delivery that might be effective, locally relevant, acceptable, and feasible to overcome those identified barriers and enhance facilitators to change. Again, hopefully there's a tight connection between the challenges we're facing and the specific strategies that we're using. And so I think there are a variety of methods that can be brought to bear to hopefully tighten those connections, and some of those I'll present on subsequent slides here. And then finally, really deciding how change can be robustly and feasibly measured. And this includes both your ultimate implementation outcomes or your proximal, intermediate, and distal outcomes of interest, as well as factors along the hypothesized causal pathway. So if there are other mediators or moderators that you might want to measure, thinking about the best way to capture those robustly in your implementation effort is important. I won't dwell on this slide too much, but I think this is a great paper by our colleague Shobha at Harvard University in the School of Public Health, who talks about different participatory approaches to implementation science, and in particular, how participatory approaches can be very useful at all stages of implementation, from identifying the interventions that we're actually implementing to thinking about the implementation determinants, strategies, mechanisms, and outcomes that we may want to assess. And so wanted to share that slide in case it's of interest to folks, but I think a lot of helpful content there. And then also on this slide, there are a couple of other papers mentioned that provide some overviews of participatory approaches to selecting and tailoring implementation strategies. So just fairly quickly, I'm going to present a few different methods for designing and tailoring implementation strategies. The first, I'm not going to go over the specific steps because I think that they are quite similar to the previous slide on developing theory-informed implementation strategies. But the first is intervention mapping or implementation mapping, which I think is increasingly common in the field of implementation science. The developers of intervention mapping primarily were in public health and health promotion, and really saw this as an intervention development protocol that was basically based on what good intervention developers do. So again, this particular steps might seem a bit generic and overlapping with other approaches you're familiar with, but I think it's been quite helpful on a number of fronts in implementation. The first being designing interventions and implementation strategies that are more implementable. So really thinking about intervention implementability from the start, and thinking about things like sustainment from the start through this approach has been helpful. It's also been used as a systematic method for adapting interventions and implementation strategies. And then finally, for developing implementation strategies and tailoring them to site-specific needs. So we've used this approach for a number of different projects now. The paper in the middle is a protocol for a study where we use this as a method of tailoring implementation strategies to site-specific needs. So this is the idea that every organization has their own strengths and weaknesses, and maybe they don't need sort of cookie cutter approaches to implementation, but we need different strategies at different sites to hopefully increase their chances of implementation success. So in this case, we used implementation mapping, or the general process of implementation mapping, to work with organizational leaders and clinicians to tailor implementation plans for their site-specific needs. We've also used this approach in a number of NIH-funded R01s, where we've had some sense of what the implementation strategy should be, that ultimately would be tested in like a cluster randomized controlled trial, for instance. But we needed some time to refine those implementation strategies at the beginning of the study. And so we've basically pitched a process where we would engage our implementing partners to design the implementation conditions prior to a randomized trial. So the paper on the right and the protocol for that study below describes a study in Vietnam where we developed a standard implementation strategy as well as a tailored approach to implementation. So basically 2 conditions of a cluster randomized controlled trial. And we ultimately showed that a tailored approach was more effective than the standard approach in both promoting fidelity to the intervention, in this case, a systems navigation and psychosocial counseling intervention. So improved fidelity to that intervention, as well as improved clinical outcomes. We've found this approach to be quite helpful, again, in giving reviewers confidence that we have a systematic approach for refining or developing implementation strategies, and also found it to be a helpful approach to making sure that our strategies are well aligned with the contextual needs that we're addressing. I know I'm running out of time quickly, so I'm going to fly through some of these. This is a evidence-based quality improvement approach, or EBQI. And again, I maybe won't dwell on the specific steps. These steps are sort of similar to many of our approaches to developing implementation strategies. But if you have time to look at this slide after the fact, there are a number of specific activities located in this table on the right that to me demonstrate that there's room for creativity in the specific methods that you use to engage your implementing partners in this case. And so it's not so much cookie cutter. There's room for creativity. There's also probably room, again, for testing different methods to see, do these different methods that vary probably in the extent to which they are pragmatic, that vary probably in terms of their methodological rigor, to see sort of, is the juice worth the squeeze for various approaches to engaging our partners and developing implementation strategies systematically. So there's a lot of room, I think, for empirical testing of these different approaches. Just wanted to mention quickly, so group model building is a system science-based approach. One of the critiques to both identifying barriers and facilitators and maybe thinking about the causal pathways of implementation strategies, that they're too often linear and don't sort of reflect the actual complexity of the settings in which we're implementing. And so this is an approach that uses causal loop diagramming to identify reinforcing and balancing feedback loops, and really understanding the complexity that we're dealing with in implementation. So it's a nice methods paper by Gracelyn Cruden. If folks are interested in this, we also have through WashU a System Science for Social Impact Summer Institute. If you're interested in system science methods, they have a number of tracks that might be interesting, including social network analysis, group model building, agent-based modeling, and others. The consolidated framework for implementation research is a common framework many of you are likely familiar with for identifying barriers and facilitators. Another sort of potentially helpful tool here is a tool that matches ERIC implementation strategies with the types of constructs that come up as barriers and facilitators, as identified through the CFR. And there are some references here that both overview the development of this tool, and then describe some evidentiary support for that tool in terms of its match with real-world effectiveness data, as well as an overview of some of the uses. But the idea here is that if we identify a barrier, this tool will spit out some implementation strategies that may be useful in addressing those. And so I always say a useful sort of first step. It's also the case that whatever strategies are suggested by this will need to be further refined and operationalized, as I've emphasized on previous slides. And this is just to say that, again, these strategies hopefully should be developed in a way such that they are usable and streamlined and as simple as possible. And we're in danger in the field of developing things that are too expensive, too clunky to actually implement. But folks have sort of bemoan the fact that we may be recreating the implementation problem with our implementation strategies if we're not careful. And so things like human-centered design are increasingly used in implementation. A behavioral economics lens also potentially useful in this field, and other approaches like most that Dr. Spring had mentioned, and other approaches that I think Billy will share next could be quite useful, and hopefully Billy will share the information about the conference upcoming on intervention optimization that I think is highly relevant to implementation science as well as intervention development. And so lastly, at least we're in the home stretch here, and we'll try to fly through some of this. There's an increasing focus on mechanisms in implementation science. This can be useful at all phases of implementation research. So there have been those that have said, why are we thinking about mechanisms? We don't even know what's effective yet. But we would argue that this could be useful even at the theorizing phase and sort of intervention and implementation strategy development phase. I will also emphasize that the approaches for depicting and studying mechanisms vary, and that opportunities to advance this work abound. This is a bit of a daunting area, at least for me and many, when we think about sort of the complexity of implementation science and really what it'll take to understand mechanisms of implementation strategy. So this is, I think, an area of the field that's going to take all of us, and hopefully many of you here will take this challenge on. So as we talk about mechanisms, we're thinking about processes or events through which an implementation strategy operates to affect the desired outcomes. This is increasingly emphasized by the NIH, and so the NIH's program announcements for implementation science have really emphasized understanding implementation mechanisms as a priority. It's also emphasized through NIMH, the experimental therapeutics approach, and others. And so I think increasingly important for the field. My colleague Pedja at the University of Michigan, who I think is not here, but happy birthday to Pedja. I think it's his birthday today, and is affiliated with the mHealth training program. And so hopefully he is having a great day. He led this paper that emphasizes a number of the key functions of understanding mechanisms, and in particular an approach called causal pathway diagramming that has been used to understand mechanisms of implementation strategies. And the first thing he emphasizes here is matching implementation strategies to determinants. I mentioned that there's often a mismatch here, but really thinking mechanistically helps us to articulate how an existing strategy is expected to work to address the plausibility of whether it can address the determinants necessary to bring about the intended outcomes. And so this is a good way of checking sort of whether our strategies are well matched to the barriers that we're addressing. It can also help us to understand the conditions under which an implementation strategy will work well. So understanding sort of the preconditions that must be present for an implementation strategy to work, and the moderators that may strengthen or weaken how well a strategy works, to understand if it will work in a particular setting and how to maximize its effectiveness. I probably won't have time to get to it, but we think that understanding mechanisms is really crucial to understanding generalizability and implementation science as well. And so there's a paper that illustrates that, I think, nicely. It can also help us to design and optimize multifaceted implementation strategies. So I mentioned we don't want to sort of recreate the problem of clunky implementation strategies. This can help us understand, like, are there redundancies in our implementation approaches? For instance, if multiple components of an implementation strategy are really addressing the same barrier, we might not need all of those components. Or if there are ways to optimize the strategy, articulating the mechanisms in a multi-level context is one way of helping us do that. It's also more scientific, so it helps us develop causal theories of how implementation strategies work. It allows us to measure implementation strategy functioning. So earlier on in the implementation process, we can see, is this helping us to move the needle on our more proximal outcomes of interest? And if not, why is that the case? And if our design allows it, can we make some adjustments early on to change that fact? And then finally, it can help us to diagnose why an implementation strategy did not work as intended. And so retrospectively, if a strategy doesn't work, why is that the case? And are there tweaks that we can make rather than sort of starting from scratch and throwing that strategy out entirely? I think for the sake of time, I'm not going to dwell on this. This is an example of causal pathway diagramming where we're really specifying proposed mechanisms, what determinants those mechanisms are addressing, and the proximal and distal outcomes, as well as the moderators that may increase or dampen the effect of these implementation strategies. The toolkit on the right, as well as the paper referenced by Pedja and colleagues on the previous slides, are great resources for this. And so this toolkit really sort of takes you from the initial steps and conceptualizing and using this causal pathway diagramming approach. And so I think would be a great resource for any of you if you're interested. We've, again, used different approaches to conceptualizing mechanisms. This is a similar but slightly different approach based on directed acyclic graphs. And in this case, we use this sort of post hoc after a study of knowledge brokering was found to have null effects on evidence-based staffing in a hospital context. And one of the things that we demonstrate through this paper is that thinking mechanistically about how this strategy will work will change the way we operationalize this strategy. In this case, knowledge brokering works in part by cultivating a social link between, in this case, knowledge brokers and hospital managers. And the status of the brokers and the positioning of the brokers in the organization is an important contextual factor or moderator of how the strategy is likely to work. And in this case, in the implementation study, they used postdocs and potentially people that within the hospital setting might not have the relational purchase that they need to actually cultivate the social link here and that relational development piece. And so that might suggest we either want to measure that ability to cultivate a social link or think very carefully about who the appropriate knowledge brokers should be in order for a knowledge brokering implementation strategy to be effective. And so feel free to take a look at that. It's a brief paper that sort of outlines the thinking there. This is I don't have time for this, but this is the effort to think about how mechanism mapping influences generalizability. So here the basic argument is that if we understand mechanisms, it's unlikely that these strategies are going to have the same effect in different contexts. But if we really map the mechanisms through which they work, we'll hopefully understand the factors that need to be considered, and how changes in those factors across settings might influence how effective the implementation strategy is, and might give us the opportunity to anticipate what those effects might be. Again, you used a number of different approaches for this. This is one where we use behavior change theory, in particular the theoretical domains framework and the Combe model, to understand the mechanisms of a multifaceted implementation strategy. This is a case in which we had a study with null effects, and Lydia Kwok and colleagues from Karolinska in Sweden have since conducted a subsequent trial where they used these frameworks to really think about the mechanisms through which these strategies work, and to test those mechanisms through a cluster randomized trial, and actually found interesting evidence for both the effectiveness of the multifaceted strategy and the mechanisms through which it operates. And so the references for at least one of those studies is below here. I mentioned system science approaches, and just to say that there are a number of system science methods that can be brought to bear in understanding mechanisms, and we think, particularly given the complexity of implementation, these are particularly appropriate. This is a recent paper in Annual Review of Public Health that gives several examples of different system science methods and how they can shed light on mechanisms. And then I might end here, or perhaps one more slide after this, but just to say, again, I think for all of you in this virtual room here, I think our work is cut out for us in terms of understanding and conceptualizing mechanisms in implementation science. We think this is really important for the advancement of the field. This is from a research agenda that we developed with support from the Agency for Healthcare Research and Quality through a multi-year conference grant. The paper on the right might seem a little bit overwhelming, but the take home for me is that there are a lot of different ways to contribute to this field, and a lot of opportunities for you all to advance our understanding of mechanisms in your work. And so hopefully you will take that on, and we'll all be better for it. I think I'm just going to end with one last slide, and just to say, as we evaluate implementation strategies, we oftentimes obviously are hoping for positive outcomes, but we know that there are also unintended consequences or ripple effects that we may have unintended positive or unanticipated negative outcomes. And so won't go over those here, but just to say there are a number of references on this slide and on subsequent slides that present both conceptual and empirical examples of unintended consequences of implementation strategies. The follow-on for me is that if we understand mechanisms of implementation strategies, that hopefully helps us to sort of anticipate some of these things. But it also goes without saying that we should be monitoring these things and hopefully being transparent in reporting these unintended consequences of implementation. So happy to take questions or discussion if we have time. I know I'm right down to the wire, so feel free to kick me out when you're ready. Thank you, though, for your attention, and again, for the opportunity to be here.
We could never implement a kickoff for you, Byron. This is terrific. I think Lindsay has posted a question in chat. Can you access that?
Is there a body of research or literature based? Yeah, that's a great question, Lindsay. I can think of multiple examples. So I mentioned the sort of the conceptual piece by Nicole Nathan about the different phases. There's also been empirical work, and now I'm drawing a blank on the last author, but it'll come to me, on building organizational readiness for implementation strategies. Like, might be an example of sort of thinking about the earlier phases of implementation and how that like the specific strategies that might be useful in doing that. There's emerging literature and maybe debates about sort of like, as we think about sustainment and scale up, like are different strategies necessary for those phases? So I think it's an ongoing question, but I think a lot of different, it's probably relatively diffuse, but I think a lot of different studies will use things like the EPIS framework, the exploration, preparation, implementation, and sustainment project to think through those different phases. Another sort of phase-based approach is Lisa Saldana has a stages of implementation completion measure, which she's empirically used in a lot of different implementation of a lot of different EBPs. And we're currently mapping that to ERIC. But the broader perspective of that is that there are different stages at different or different strategies at different stages that are likely important and necessary. And so I think all of those would be probably at least helpful reference points.
Well, that brings us to the top of the hour. Dr. Powell, thank you.